Surgery and Genetics. Respected sir, Emeritus Chairman Dr. M.L. Sonka sir and all others. We have started in the department in September 2012 and we started with few dialysis machines and a few dialysis sessions, and then we started kidney transplant program in November 2012. So far this is our journey. We started with 2 kidney transplant in 2012 and so onwards in 13, 25 and then 283 and then in 2023 402 highest number, and now we are doing almost 300 plus kidney transplant in a year. There are few hurdles in the kidney transplant program. After the CCR we will discuss with you sir in the on meeting. So far we completed 2,700 kidney transplants. One of the milestone of our department or institute, one of the leading kidney transplant center in the India and maximum number in the state. Also we did the first swab kidney transplant in July 2014. Swab means there are 2 patient is A group, donor is B group. They are easily exchange their kidneys. So we did the first swab state as well as the in the 2014. Also we did the first disease donor kidney transplant in the state, that is 6th Feb 2015, and so far we have completed around 170 plus swab transplant, and also we did the first ABO incompatible transplant over state in the March 2016, and so far we completed 250 kidney transplant. By doing the ABO incompatible, if patient is O group and their family members is not having the O group, they are having A group, B group or AB group. So in these patients we can do the transplant by the ABO incompatible technique. So patient get the transplant and we can increase the transplant pool up to around 30%. Also we did the state first 3-way transplant and the first 6-way transplant in the private sector in the India. That is where first institutes did the first 6-way transplant. Also we started the robotic kidney transplant in our institute, and we started with the few dialysis machines. Now we are having the state-of-art dialysis unit as well as the around 50 dialysis machine for the conventional dialysis patients, and also we are having the for the critical patients we are having the SLAD and the CRT machine in the ICUs. So this is the one of the largest dialysis providing center in the state as well as in the India, which is providing all world-class dialysis facility in our institute. We are doing almost 2,800 kidney dialysis sessions per month. Also, we have established in 2012 our international interventional nephrology department in the state. This is the first center which is providing all kind of interventional nephrology in form of USG guided kidney biopsies, USG and fluoroscopy guided tunnel and non-tunnel catheters, AV fistula. Our department is itself doing the unique surgical work and also CAPD catheter insertion. In the October 2015, our institute and our department of our nephrology did the organize the ISOT Indian Organ of Transplant 2025 conference in the with the chairmanship of Dr. M.L. Sonka sir. It was a very successful conference which raised our institute name in the state as well as in the national level and international level. Almost more than 50 international pioneer in the liver and kidney transplant have attended this program. One of that is, as you all know, the xenotransplantation, that is a genetically modified pigs kidney transplant undergoing in the last few years. This is Dr. Robert Montgomery, which is also attended this conference. So also we got the certificate of excellence in the swab transplant program, and also we are having the DM program. We started in the 2016 1 seats. Now we are having the 4 seats per year. So far more than 13 students have passed. They have all are settled in the different states of the country: Punjab, Haryana, Delhi, Nagpur, Bihar, Uttar Pradesh. All are doing good work in the dialysis as well as the transplant program. They all are carrying forward our legacy of the Mahatma Gandhi Hospital in the nation. We are having more than 90 publications, and अभी we did the last 12 years so much work in the leadership of Dr. M.L. Sonka sir. So now we are having the carrying forward MGS है तो भरोसा है. But last 14 years that is the vision of our sir M.L. Sonka sir. I am saying Dr. M.L. Sonka sir है तो सब कुछ मुमकिन है. महात्मा गांधी में भी मुमकिन है. Now I would like to invite Dr. Jasleen to carry forward.
Good morning everyone, respected Emeritus Chairman Sir, respected faculties, teachers and my fellow colleague. I, Dr. Jasleen Kaur, second year DM Resident from Department of Nephrology, welcome you all for this CCR highlighting from rare kidney disease to renal transplantation, a challenging story in a young male. So, this is a case of a 22-year-old male student hailing from Alwar, belonging to a middle socio-economic background, presented to nephrology OPD at Mahatma Gandhi Hospital in Feb 2024 with chief complaints of loss of appetite since last 2 months, decreased urine output for 10 days and progressive breathlessness on exertion since 5 days. He also developed bilateral lower limb swelling since the last 5 days. Coming to the history of presenting illness, the patient had loss of appetite for the past 2 months with a significant reduction in oral intake from around 2 to 3 chapatis per meal 3 times a day to only 1 chapati twice daily. This was associated with generalized weakness and nausea. He also complained of decreased urine output for the last 10 days with urinary frequency reducing from 4 to 5 times a day to twice a day. The patient presented with breathlessness and exertion for the last 5 days. It was insidious in onset, non-progressive and occurred mainly during exertional activities such as hurrying or walking upstairs. There was no history suggestive of orthopnea or paroxysmal nocturnal dyspnea. He also noticed swelling of both lower limbs since 5 days, gradual and progressive in onset, pitting in nature, extending up to the knees and was associated with facial puffiness. Coming to the negative history, there was no history of fever, night sweats, cough, hemoptysis, significant weight loss, vomiting, decreased sleep, altered talks or altered body movements, yellowish discoloration of eyes, rashes, joint pain, hearing and vision loss, hematuria, chest pain or palpitations or chronic analgesic abuse. So, coming to the past history, at the age of 14, in 2016, the patient had an episode of hematemesis. Following this, he consulted a local gastroenterologist, after which ultrasound whole abdomen and upper GI endoscopy were advised for further evaluation. Ultrasound whole abdomen in 2016 was suggestive of portal vein, which was replaced by portal cavernoma, splenomegaly. During the same time, renal evolution showed bilaterally normal sized kidney, increased cortical echogenicity and maintained corticomedullary differentiation. On upper GI endoscopy in 2016, large esophageal varices were identified as the cause of hematemesis and the patient subsequently underwent endoscopic variceal ligation in 2016. Following the episode of hematemesis in 2016, baseline investigation were done at that time and platelet count was 1.3 lakh, suggesting mild thrombocytopenia was present from the early stage itself. The patient already had evidence of mild renal dysfunction with serum creatinine of 1.6 and blood urea of 51 with normal urine routine examination. Patient was on irregular follow-up in his hometown with a general physician. Despite conservative management, renal function showed a gradual progressive decline over the years with serum creatinine rising from 1.6 in 2016 to 5.1 in 2023. In 2023 to 2024, the patient also took alternative Ayurvedic medication. Eventually, By 2024, when patient presented to us, the creatinine had already progressed to 9.1. Another important feature in this patient was persistent thrombocytopenia over the years. As shown in the graph trend, platelet counts gradually declined from 1.3 lakh in 2016 to nearly 88,000 at the presentation in February 2024. Now, coming to the family history of the patient. In the index case, renal dysfunction was detected at the age of 14 as an incidental finding during evolution of hematemesis. On exploring the family history further, a striking pattern of kidney disease were noted across the multiple generations. The patient grandfather and father also had chronic kidney disease. Patient's two buas similarly succumbed to chronic kidney disease, while one bua underwent kidney transplantation. Coming to the third generation, patient's elder brother went kidney transplantation in 2022 at our hospital. Multiple paternal cousins were also affected with chronic kidney disease, with one cousin requiring maintenance hemodialysis.
So when you make a pedigree chart, at the age at which the patient dies, that should also be mentioned in the bracket. No, was it a young death or was it a death at age 80, 90? There are different connotations, right? So that just father slash then age, that would indicate what approximate age the patient expired.
Yes, sir. As there was strong 3-generational chronic kidney disease history, with several progressing to end-stage renal disease and 2 already undergone renal transplantation, this strongly pointed towards an inherited renal disorder. Thus, genetic testing of the paternal family was advised. So, showing this pedigree.
History, what it suggests? It suggests recessive disorder or autosomal?
Autosomal dominant, sir. Coming to the general physical examination, patient was conscious, cooperative and well oriented to time, place and person. Height was 177.8 centimeter, weight was 69.5 kgs and body mass index of the patient was 22 kilogram per meter square. Pulse rate was 88 per minute. Blood pressure was 140 by 78 millimeters of mercury. Respiratory rate was 24 per minute and patient was afebrile. On systemic examination, respiratory examination revealed bilateral air entry with bilateral basal crepitations. Per abdomen examination showed a soft, non-tender abdomen with palpable splenomegaly 9 cm below the left costal margin in the sphenoumbilical line. And cardiovascular neurological examination were unremarkable. To summarize this case, 22-year-old male who presented to us in February 2024 with symptoms suggestive of advanced renal dysfunction, including loss of appetite, decreased urine output, breathlessness on exertion, bilateral lower limb swelling, with the past history of an episode of hematemesis at the age of 14 due to esophageal varices, for which endoscopic variceal ligation was done in 2016. In this case, there was very strong family history of chronic kidney disease involving multiple paternal family members across the 3 generations. His renal function deteriorated over the years with serum creatinine from 1.6 in 2016 to 9.1 in February 2024, eventually progressing to end-stage renal disease. In parallel, he also had persistent thrombocytopenia, which progressively worsened over the time. So, now I would like to ask the audience, based on this history and clinical examination, what can be the clinical possibilities? Okay.
Medical residents in the audience, what could be the cause of thrombocytopenia in this patient? You've heard the history and the investigations. What is the possible cause of thrombocytopenia? Can you just, stand up, identify yourself and then shoot? Yeah, come on. Just stand up. Identify yourself. Correct. And splenomegaly because of? Good. Very good.
One has to think of polycystic kidney diseases. A dominant sort of inheritance is there, so that should come into the first.
Yes.
All right.
So, the first clinical possibility is autosomal dominant polycystic kidney disease. Second can be Alport syndrome, and chronic liver disease is secondary liver dysfunction, and familial focal segmental glomerulosclerosis. So, these are the lab parameters when he presented to us in 2024. Hematological evaluation revealed pancytopenia with platelet count of 88,000, and this patient had markedly deranged renal function with blood urea of 182.8 and serum creatinine of 9.1.
So when you show a low TLC, you have to show the granulocytes and the lymphocytes, no? If you're saying, say, marrow suppression, then the lymphocytes will be normal, granulocytes will be decreased. So the DLC should also be shown.
Yes.
Correct? Agreed?
Yes, agreed. On evaluation, patient's estimated glomerular filtration rate was 8 ml per minute per 1.73 meter square. So at presentation, the patient had already progressed to advanced chronic kidney disease requiring renal replacement therapy. Ultrasound whole abdomen done in February 24 showed a normal sized liver with preserved ecotexture. However, the portal vein was replaced by periportal collaterals suggestive of portal cavernoma formation, indicating chronic portal hypertension. Multiple periportal, perigallbladder, peripancreatic collaterals were also noted. The spleen was enlarged, measuring approximately 20.1 cm. Both kidneys appeared small, contracted, with increased cortical echogenicity and loss of corticomedullary differentiation, suggestive of bilateral chronic medical renal disease. So, based on the overall clinical picture, our provisional diagnosis was chronic kidney disease progressing to end-stage renal disease. The very strong family history involving multiple members of familial chronic kidney disease was considered to be native kidney disease. At the same time, the patient also had extrahepatic portal vein obstruction with portal hypertension. Additionally, the patient had a past history of variceal bleed and was post-endovariceal ligation on pharmacotherapy. In view of such strong family history of kidney diseases along with multi-system involvement, an inherited genetic disorder was strongly suspected. Case was referred to medical genetics department and whole exome sequencing was advised for further evaluation. Now, I would like to invite Tejas sir from Advanced Center of Medical Genetics to further highlight the genetics aspects of the case.
Thank you so much, ma'am. Respected Chairman, sir, and faculty members and colleagues, I am Tejaswiram Tolety, working as Senior Scientist in Advanced Center for Medical Genetics. So the case was with strong familial history and having vertical transmission of the disease along with the reduced onset of age. The parental generation are having the disease at age of 5th decade, and then the later family members are deceased at the age of 44 years approximately, and then the current generation was having disease at the age of 14 to 16 years of its age. Now, as per the autosomal dominant condition, the whole exome sequencing was advised. In whole exome sequencing, where the protein coding regions and the splice site regions were assessed in approximately 20,000 plus genes, and the whole exome sequencing results are showing the involvement of third gene, which is telomerase reverse transcription disease, reverse transcriptase. The protein was founded on 5th chromosome short arm, and which is a heterozygous variant was discovered and there is a replacement of threonine with methionine at position 26. And coming to the protein identification, so the protein cause will be showing a probably damaging effect of substitution of threonine by methionine, because threonine is an polar and then the methionine is a non-polar amino acid, and later on we cannot diagnose simply with the variant effect with the help of protein functional studies. So we have to see the remaining parameters according to the ACMG classification, where the reputable databases are showing it is an uncertain significance because of only one submission around the world, and afterwards we have to see the population database where the normal population were assessed. So the 1000 Genome Project and Nomad AD are the two reputable healthy population databases, where in 1000 Genome database it was not reported, and in Genome Nomad AD it was very slightly published around 0.07% as a minor allele frequency, and there are no functional studies are published, and there is no literature which suggesting of the effectiveness of this protein, and the segregation pattern, where we have also screened the elder brother of the patient, which is having the same kind of amino acid variant solely in the patient, so which is suggesting of segregation from the ancestors only, and the protein was conserved across the mammals, and so we will also consider the limitations of the whole genome sequencing. So in whole genome sequencing we cannot identify copy number variants strongly, and we cannot assess the repeat expansions, and we cannot see the translocations, and we cannot see the chromosomal rearrangements, and we cannot see completely the untranslated regions and promoter regions and deep intronic regions. Coming to TERT gene, which is also having a published data on promoter regions also, which is having a causing of disease in various other types of disease expression. And coming to points of consideration, we have to see the segregation analysis of the remaining family members, and telomere length has to be assessed, and there is no function data as of now available, and with the help of this exome sequencing we can identify the candidate gene which is responsible for the phenotypic progression. Thank you.
So, to briefly summarize the case, this was a young patient with progressive familial kidney disease, long-standing portal hypertension, persistent cytopenias, and gradual progression to end-stage renal disease. After detailed evolution and genetic workup, the final diagnosis was chronic kidney disease, grade 5D, secondary to chronic tubulointerstitial disease due to telomerase reverse transcriptase mutation as the native kidney disease. The patient also had extrahepatic portal vein obstruction post-endovaricial ligation managed on pharmacotherapy along with pancytopenia and hypersplenism. Once the patient progressed to end-stage renal disease, hemodialysis was initiated for renal replacement therapy. After stabilization, available renal replacement options were explained to the patient and his family members whether to continue on maintenance hemodialysis or opt for renal transplantation. The patient and family members opted for renal transplantation. His 46-year-old mother was evaluated as potential living donor. She was blood group compatible, and a donor renal function assessed via DTPS scan was adequate for both the kidneys. Till definitive treatment, till definitive transplant could be planned, the patient was continued on maintenance hemodialysis at our center. Now, I would like to ask the audience, which is better, which is generally considered the better option in as long-term renal replacement therapy? Renal transplant generally provide a better quality of life, improve long-term survival compared to hemodialysis. Patients are relatively free from repeated dialysis sessions, usually having fewer dietary and fluid restriction. Although the upfront and surgical risks are higher, transplantation is more cost effective in a long run. However, transplant recipients require lifelong immunosuppression and regular follow-up due to the risk of infection and rejection. On the other hand, hemodialysis is more readily available, avoids major surgery, but it is associated with repeated hospital visit like twice weekly, thrice weekly, and strict dietary and fluid restriction, vascular associated complication, intradialytic hypertension, lifelong dependence on dialysis. The sessions are also time consuming and significant affect the daily activity. So there are pros and cons of everything, but in this case renal transplantation was the better option. As part of pre-renal transplant workup, multidisciplinary clearances were obtained. Medical gastroenterology consultation was sought in view of splenomegaly and past history of hematemesis with endovascular ligation. Cardiology and psychiatry evaluation were unremarkable with no active intervention required. Hematology opinion was taken for persistent thrombocytopenia. Persistent thrombocytopenia was present since 2016, and then platelet count gradually declined and was 88,000 when he presented to us and kept on declining. Hematology consultation was sought. Bone marrow aspiration and biopsy were advised to rule out primary marrow pathology. The study revealed hypercellular marrow with preserved megakaryocytes suggesting preserved marrow function. Therefore, thrombocytopenia was attributed to hypersplenism secondary to significant splenomegaly and portal hypertension. Considering the planned renal transplantation, splenectomy was advised as a pre-transplant optimization strategy. Now, I would like to invite Dr. Sumedh from Medical Gastroenterology Department to further discuss the case.
Thank you, Dr. Jasleen. Good morning, respected Chairman, sir, and teachers. My name is Dr. Sumedh, and I will be presenting further under the guidance of Dr. Sandeep Nijavan and Dr. Karan, sir. So, why was medical gastroenterology consulted? Nephrology department referred the patient for evaluation of persistent thrombocytopenia in context of planned renal transplantation. Key findings that prompted the referral were history of hematemesis and persistent thrombocytopenia, a palpable spleen 9 cm below the left costal margin along its long axis extending towards the right iliac fossa with smooth surface, firm consistency, distinct notch, moving with respiration and unable to insinuate fingers above the swelling, suggestive of massive splenomegaly. Past history of large esophageal varices with prior EVL sessions. So this basically confirmed the clinical diagnosis of portal hypertension. Portal hypertension can be divided based on the level in these causes, post-hepatic, hepatic and pre-hepatic. In our case, we will be dealing with the pre-hepatic cause of EHPVO. Why this patient has EHPVO? So when this patient presented to us for evaluation, his latest upper GI endoscopy again showed small esophageal varices with previous EVL scar. And on his repeat ultrasound also there was a portal cavernoma with collaterals and splenomegaly, as well as PHG was also seen on upper GI endoscopy. CCT abdomen was done, portal vein was not visualized, portal cavernoma formation was there, multiple collaterals and lienorenal shunts with massive splenomegaly, splenic artery pseudoaneurysm, liver was normal essentially, and fibroscan was also done which showed normal LSM. The synthetic liver function was completely preserved, normal albumin, normal INR, absence of ascites, no other features of hepatic decompensation like ascites or HE except GI bleed was the only presenting symptom. So final diagnosis was chronic EHPVO with prehepatic portal hypertension. So why this is a GI barrier to renal transplant? Severe hypersplenism induced thrombocytopenia created a major perioperative risk that rendered renal transplantation unsafe in this patient's current state. There was perioperative bleeding risk, severely low platelet count creates unacceptable risk of uncontrolled surgical bleeding. There was a vascular challenge that thrombocytopenia significantly increases the difficulty and complication during vascular anastomosis. Increased intra-abdominal collaterals also increase surgical risk. and transfusion requirements that increase, and also they are associated with immunological risk. So the key objective of medical GI evaluation was converting an unsafe transplant candidate into a transplant eligible patient through definitive portal hypertension management by identifying hypersplenism as the reversible barrier. So what was the justification for referral to HPB surgery? The renal transplant that was required, but platelet counts were critically low, so transplant was unsafe without correction of underlying hypersplenism. EVL had already been performed. It controlled bleeding but could not correct thrombocytopenia and PHG or reduce the transplant risk. Hence, HPB surgery was taken into opinion, and splenectomy and shunt surgery were advised. Splenectomy to correct hypersplenism and restore platelet counts, and shunt surgery as the definitive treatment of portal hypertension. These interventions address the root cause, not just the symptoms of this patient's transplant ineligibility. Operative details fall within the domain of HPB surgery. I would like to invite Dr. Akshat, sir.
Everyone. So we have a case of EHPVO with portal hypertension, hypersplenism in a case of end-stage renal disease. After proper PSC fitness and preoperative vaccination, patient was taken off for splenectomy with proximal sphenorenal shunt, and the platelet counts at the time of surgery were 25,000. Looking at the preoperative CT scan, we can see there is an extensive collateral formation that has been formed over time around the spleen, and there is no proper portal vein, instead a portal cavernoma formation due to EHPVO with multiple periportal and peri-CBD collateral formation. We can also see there are numerous collaterals that has been formed around the splenic hilum. To note that spleen is massively enlarged and reaching up to the iliac fossa, covering the majority of the left side of the abdomen. So as we can see over here, in the extrahepatic portal venous obstruction, there is a portal vein cavernoma formation that leads to the increase in cavernoma portal pressure, leading to portal hypertension. With time, there are numerous collaterals formed around the periportal region, perisplenic, perigastric region as well. So there are numerous challenges that can be anticipated before the surgery, like extensive collaterals, dense perisplenic adhesions in view of recurrent inflammation and perisplenitis. There was expected capsular oozing in view of severe thrombocytopenia prior to the surgery. Also, there was a splenic artery pseudoaneurysm prior to the surgery that had to be tackled intraoperatively. Correlating with the intraoperative findings, what we can see here are only few of the many collaterals that were found during the surgery and had to be ligated off. This is the splenic artery aneurysm which was ligated during the Hyler control. Here we can see how spleen is densely adherent to the adjacent structures and requires a meticulous and careful dissection so as to prevent capsular bleeding. It is densely adhered to omentum and lateral and anterior abdominal wall, requiring careful dissection. Important to note is that however small a collateral might be, it has the potential to cause torrential bleeding. As we can see over here, the sputter. Any small collateral may cause this kind of bleeding and requires all collaterals required to be carefully ligated. Sometimes due to, as we discussed earlier, recurrent perisplenitis and inflammation, there are densely adhered structures to the spleen. We can see here is the part of left lobe of the liver which was so adherent to the spleen that it had to be removed as part of the specimen along with the spleen. To briefly understand the regional anatomy, we have spleen over here. This is the liver, pancreas. Behind the pancreas, we have portal vein supplying the liver, which has been formed by splenic vena and superior mesenteric vein, draining the intestines along with the inferior mesenteric vein. So what happens here, due to portal cavernoma formation, there is an increased periportal pressure. So in the surgery, first of all, the splenectomy is done to correct hypersplenism. Then the proximal splenic vein is anastomosed with the left renal vein, so as to effectively divert the portal flow from the portal vein to the inferior vena cava via left renal vein, and thereby reducing portal hypertension. Here we can see this is the left renal vein that has been looped, and this is the proximal splenic vein which was preserved during the splenectomy. After applying the clamp, it is being prepared for the anastomosis. A partial slide clamp is applied on the left renal vein, and a venotomy is done to prepare for the anastomosis. An end to side splenorenal anastomosis is done. After the shunt, a distal clamp is removed first, followed by the removal of proximal clamp. And this here is the completed splenorenal shunt, which will decrease the portal vein pressure and reduce the portal hypertension. As we can see, spleen was massively enlarged, measuring around 18 to 20 centimeters in length, and this is the part of the left lobe of liver that had to be removed along with the spleen. Looking at the post-operative course.
Just a technical question. How will you ensure the safety of the tail of pancreas during splenectomy? Very general observation.
Sir, will be more towards the splenic and the hilum. Pancreas is more laterally than the spleen. So in this case, the vessels need to be ligated more towards the splenic side of the vessel and to be.
It is very important to remain towards the hilum of the spleen, because when I was in West Africa, there's a lot of splenic injuries, hemorrhage. Splenomegaly was there because of the endemic malaria. All right. So they will come with the hemoperitoneum, massive hemoperitoneum. So you have to be very, very careful. Otherwise, you can easily damage the pancreas, and that is almost fatal. So one has to be as close to the spleen.
Looking at the post-operative course, patient was shifted to ICU after the surgery for monitoring. Early ambulation and oral feed was started from day 1. Patient was taken up for hemodialysis on day 2 and was shifted to ward after early removal of abdominal drain on day 3. Patient had an uneventful recovery and discharge on anticoagulation on day 4. Looking at the trend of complete blood count picture, you can see patient had severe pancytopenia preoperatively with HB of 6.3, total leukocyte count of 1100 and platelets of only 25,000, with a drastic improvement immediately after the surgery with HB increasing to 8.43, total leukocyte count to 14,000 and platelets improving to 49,000 on day 1 with reaching nearly normal limits of 1,20,000 on the day of discharge. Patient was referred back to nephrology and I would like to call Dr. Fuzail to discuss on the further management.
Good morning everyone. Myself Dr. Fuzail, third year DM resident in Department of Nephrology. Now to continue onwards, after splenectomy, patient was monitored for 8 weeks. This is a line diagram showing platelet trend pre and post splenectomy. As we can see, after splenectomy, the platelet started increasing, and on November 2024, the platelet was 1,87,000. We monitored the patient for 8 weeks. As the patient did not have any complication and platelet was on increasing trend, so we moved towards the transplant. Legal formalities was completed, an OC obtained from the authorization committee. Patient was admitted 2 days prior to the planned renal transplant surgery. Patient underwent a successful renal transplant on 19th November 2024 with the induction being basiliximab 20 mg on day 0 and day 4. Methylprednisolone was given 500 mg intraoperatively, and from POD1 to POD4 he was given 250 mg methylprednisolone. On day 5 of renal transplant surgery, patient was shifted to oral prednisolone and was initiated on triple immunosuppressive medication, that is prednisolone, tacrolimus and mycophenolate mofetil.
So can you tell us what is basiliximab and why is it given?
Basiliximab is a monoclonal antibody directed against IL-2 receptor, which is responsible for which inhibit T cell maturation and proliferation. So it reduces the immunity of the patient, so the rejection episode does not occur in the patient. Intraoperative outcomes: patient had minimal blood loss, approximately 190 ml blood loss during the entire procedure. No transfusion was required as patient had no intraoperative blood transfusion required, validating the pre-surgical optimization surgery. Post-operative period, patient was shifted from kidney transplant ICU to private ward on post-operative day 4. As the patient was stable with no intra, peri and post-operative and medical complication, he was discharged on post-operative day 7 of renal transplant surgery at a creatinine of 1.2 mg per deciliter on triple immunosuppressants. Long-term maintenance and stability, he was maintained on standard triple therapy, that is prednisolone, tacrolimus and mycophenolate mofetil. Patient had stable graft function at 12 months and following years until now with no episodes of rejection, no episodes of complications such as hematological, pulmonary, hepatic or opportunistic infection complicated reported. Platelet recovery post-renal transplant, as renal transplant was done in November 2024, platelet started increasing and at present the patient had 3,44,000 platelet count. Now patient has stable creatinine of ranging from 1.0 to 0.7. To summarize, a 22-year-old male presented with CKD, a chronic kidney disease, and features of volume overload. Past history of hematemesis at 14 years due to esophageal varices, managed with endoscopic varicose ligation and medical therapy. There is a strong 3-generation paternal family history of chronic kidney disease. Genetic testing confirmed native kidney disease to be chronic tubulointerstitial disease due to telomerase reverse transcriptase mutation with associated extrahepatic portal vein obstruction, hypersplenism, and pancytopenia. Patient was initiated on maintenance hemodialysis and underwent splenectomy for hypersplenism. Subsequently, underwent successful renal transplantation with good graft function and stable creatinine on follow-up. Now coming on to the discussion.
You have replaced the kidney within the new organ.
Yes.
The third mutation is very much still present in the patient. Yes. Is it likely to have an effect on the
graft kidney, there is no case reported because according to our best of the literature which is published in India, only one case has been reported till date of TRT mutation.
That's right. So that doesn't mean it won't happen. One case doesn't prove that this is the law.
It can happen.
What is the risk for the patient for the new kidney?
Sir, risk is as that of normal patient who do not have mutation, because it has not been reported and we are on follow-up since 2 years.
वैसे भी सर ये जेनेटिक है, टेलोमरेज रिवर्स ट्रांसक्रिप्शन है, तो जो डोनर किडनी वहाँ कहाँ से आ जाएगा? It cannot be acquired by, I think so.
No, but in continuation of what Dr. Saraswat said, see, EHPBO, some groups believe is a manifestation of a prothrombotic state. In fact, some groups do routine coagulation profile workup in these patients, and if it is found to be abnormal, they put the patient on long-term, preferably lifelong anticoagulation. Now, here is a patient who has EHPBO, which could be a procoagulant state, and has a chronic kidney disease. I would like to know what was the status of the renal veins, either on ultrasound or CT, and in the explanted kidneys, did the pathologist look at the renal veins? Was there any thrombosis there? And I would suggest that the patient as well as the entire family should probably undergo a detailed coagulation profile workup, and if they are found to have a procoagulant state, then preferably they should be put on anticoagulation.
So I also have a theory to propose. Maybe the TERT gene mutation which the patient has, which is really unusual, not reported, not discussed. Maybe this mutation is also producing the vascular abnormality, the pre-sinusoidal cavernoma.
Yes, sir.
Right?
This case have been reported.
Just answering sir's question, Dr. Kapoor sir's question, we don't remove kidney in kidney transplant. You should have answered that question. The difference between liver transplant and kidney transplant is you don't remove the native kidney.
Yes.
So there is no way. Sir had asked, you remove the native kidney and send it for histopathology, what happens to the renal vein? So you don't remove the native kidney. So you will never get what has happened in the native kidney. So that the new kidney is implanted in the iliac fossa.
Yes, sir. Right.
Separate, which is not exactly orthotopic. Orthotopic and heterotopic. I'm sure you would know that.
No, in some cases we remove renal nephrectomy in case of if there is large polycythemia, there is no space, no renal bed available.
Graft nephrectomy, you should have answered that. You didn't answer that question. Routinely we never remove kidney. We never remove kidney. And plus this patient was evaluated pre-operatively.
Yes.
So you should answer the questions what he has asked. The renal veins were evaluated on the CT scan. That is why we were able to do a splenorenal shunt as well. So the question is very pertinent, and you will maintain this patient on long-term anticoagulation, no? Specifically because of shunt also.
Yes.
Right?
But I was referring to microthrombi in the small vein. So if the group agrees that this could be a possible cause, then a biopsy can be done from the native kidney.
I think regarding the thrombophilic disorders in EHPBO, there are good studies from India, AIMS and also Lucknow which show that less than 1% of the idiopathic EHPBO which we commonly encounter in our country has any thrombophilic disorder. Much higher, 20% in the Budd-Chiari syndrome. And I think no other family member you have an extensive detailed history has a history of splenomegaly or hypertension.
No.
So to think that these are linked, I think is unlikely. even whether due to a gene or due to a thrombophilic disorder. It's probably one of those coincidental idiopathic EHPVOs that has happened in this individual.
Now moving forward to discussion, telomere biology disorder or telomere reverse transcriptive disorder. Telomere biology disorder. Telomeres are the protective caps at the end of our chromosome. Telomerase is an enzyme that protects these end of the chromosome. Every time a cell divides, telomere becomes shorter. When they become too short, the cell stops dividing or dies. Telomerase reverse transcriptase enzyme helps rebuild telomeres so cells can continue dividing normally. Now, if there is telomere dysfunction, there is defective telomere maintenance leading to cellular aging and apoptosis, leading to progressive organ dysfunction. Major systems which can be affected by telomere dysfunction could be bone marrow, skin and mucosa, lungs, liver, and kidney. Clinical spectrum of telomere biology disorders, pediatric versus adult. In pediatric onset, most classical phenotype is dyskeratosis congenita triad. It is characterized by triad of oral leukoplakia, nail dystrophy, reticular skin pigmentation. Adult onset is more of a atypical, incomplete or cryptic manifestation presenting in the second or fourth decade of the life. It may have isolated organ failure, isolated cytopenias, often misdiagnosed initially. Adult onset disease frequently lacks classical mucocutaneous manifestation. Now this is the pictorial presentation of the classical dyskeratosis congenita. It shows reticulate hyperpigmentation, nail dystrophy, oral leukoplakia, premature graying of hairs, and dental abnormalities. Organ which can be involved in adult onset, if there is hematological involvement, it can lead to pancytopenia or marrow failure. If renal involvement is there, it can lead to chronic tubulointerstitial disease, which leads on to chronic progressive kidney disease. Lungs, it can lead to pulmonary fibrosis. Liver, non-cirrhotic portal hypertension, fibrosis or cirrhosis of the liver can occur. Oral leukoplakia, skin pigmentation, and immune dysregulation leading to recurrent infection. Now coming on to the renal manifestation of this disease, the most common type is chronic tubulointerstitial disease, leads on to chronic kidney disease. Second most common is focal segmental glomerulosclerosis, characterized by nephrotic range proteinuria, glomerulosclerosis, and progressive renal failure. Rarely it can cause cystic kidney disease. Now coming on to the renal pathophysiology, how renal is involved. Telomere shortening leads to reduced regenerative capacity of the renal tubular cells, leading to tubular atrophy and fibrosis, leading to chronic kidney disease. Additional contributors of progression of chronic kidney disease could be chronic inflammation, oxidative stress, bone marrow dysfunction, and immune dysregulation. Now, renal transplantation in telomerase reverse transcriptive disorder. Organ transplantation remains the definitive treatment for end-stage organ failure in telomere biology disorder. However, transplantation is challenging because of cytopenias, infection risk, liver involvement, pulmonary complication. Careful pre-transplant optimization and long-term monitoring are essential. Why this case is rare globally? Telomere biology disorder themselves are very rare. Renal involvement in telomerase reverse transcriptase associated telomere biology disorder is uncommon compared to pulmonary, hepatic, or hematological manifestation. Progression to end-stage renal disease requiring renal transplantation is even rare. Published literature describing kidney transplantation in genetically confirmed telomerase reverse transcriptase mutation remains extremely limited worldwide. Most transplant experience in telomere biology disorders involve hematopoietic stem cell transplantation, lung transplantation, and liver transplantation. Now, Indian perspective of this, only one published Indian transplant report in telomere biology disorder identified on literature review. This case was published in 2024 at PGI Chandigarh of combined liver kidney transplantation. No clearly documented published Indian report of isolated renal transplantation in genetically confirmed telomere reverse transcriptase mutation. To the best of our knowledge, this will represent the first reported Indian experience of renal transplantation in renal brothers with genetically confirmed telomerase reverse transcriptase mutation associated end-stage renal disease. Why this case was extraordinary? Young end-stage renal disease patient with multi-system genetic disease, two real brothers affected with genetically confirmed telomerase reverse transcriptase mutation, severe portal hypertension with massive hypersplenism, platelet count reached nearly to 25,000, initially considered a high-risk transplant candidate, required coordinated management across 4 super specialty departments. With the help of multidisciplinary approach and interdepartmental coordination, we could successfully do isolated renal transplant at our center with a stable long-term graft outcome. Key learning points: familial chronic disease requires evaluation beyond common etiologies. Cytopenias with chronic kidney disease should raise suspicion for genetic syndromes. Telomerase reverse transcriptase mutation may present without classical dyskeratosis congenita phenotype. Portal hypertension may coexist with preserved liver function. Hypersplenism can become a reversible barrier to transplantation. Multidisciplinary optimization can enable successful transplantation even in complex genetic disease. Abstract of this case has been published in Indian Journal of Transplantation Conference Proceeding. Full case report manuscript submitted for publication in Kidney International Report expected to be published this year. Conclusion: from telomere trouble, with the help of multidisciplinary approach and interdepartmental coordination, transplant triumph could be achieved at our institute. This case highlights the strength of comprehensive nephrology-led multidisciplinary care, where peri-transplant optimization and long-term renal follow-up collectively transformed a high-risk patient into a successful renal transplant recipient. Thank you.